Thanks so much, Greg. And we're always happy to partner with Mask. And as Greg said, I'm Barbara Fain. I'm the executive director of the Betsy Lehman Center for Patient Safety. It's wonderful to see this turnout here, and I know some other people will continue to join as we go along. I am joined by my colleagues. Terrell Smith, who's the director of the Bureau of Healthcare Safety and Quality at the Massachusetts Department of Public Health, Kate Saunders, who's the director of quality improvement in DPH's Bureau of Healthcare Safety and Quality, and then Daniela Brown, who is director of the Quality and Patient Safety Division of the Board of Registration in Medicine. We can go to the next slide. And we're going to tell you there are a lot of agencies here, and I'm going to give you kind of a quick overview in a second of sort of the different roles that we play. But we have kind of a packed agenda, and we want to leave time at the end for your questions. And actually, probably a good time for me to say, when we get to the Q&A, feel free along the way to add your questions into the chat, or there's also an opportunity at the end if you just want to use the hand raising function. If you just want to, have speak out your questions, that is also fine too. But don't be afraid to. We actually encourage you to think about your questions and add them into the chat as we go along. So what we're going to do in the next hour is I'm going to start off with kind of a high-level overview of how the state oversees healthcare safety and quality in the ASCs, and what the patient safety landscape looks like in Massachusetts today. And then my the Bureau of Healthcare Safety and Quality and QPSD colleagues are going to do a deeper dive into safety culture and quality improvement concepts, and also talk about their agency's mandated reporting systems. And finally, we're going to point you, there actually are quite a few resources available to you to help you do this work, and we're going to give you kind of a quick overview of those. And what our primary objective, I would say, is for you to leave here today with an understanding that even though the ASCs are a regulated industry, and some of us presenting today are regulators, we also can be a resource in helping you do what we know is most important to everyone, which is ensuring that every patient that you and your facility serve has the best possible outcome. And also this is you're getting to sort of meet some of the players and connecting names to faces so that you can be in touch with them directly afterwards. Next slide. So before we get started, we have a quick poll. Janelle, if you could pull that up, and I want to assure you that we cannot see. We'll share the results of this. We cannot see we cannot connect your names to your responses. So please feel free to just answer honestly. It's really just to give us a better sense of kind of what your levels of understanding are about all of these issues, and particularly the reporting requirements. There are two questions you might have to scroll down to get to the second one. So we'll give it just a few more seconds before we pull up the results. So I think it's slowing down. So Janelle, if you want to pull up the results, that'd be great. Okay, so you can see, is everyone seeing the results? Okay.
Yes.
Okay, good. So good to see that that all of you agree that you believe that you can identify harm events when they happen, and but it seems that in terms of knowing how and when to report events to the state, there are kind of varying levels of confidence. So anyway, we could take that down, and if we could go to the next slide and actually just Yep. We can, next slide. Okay, so let's just start off, and I'm not going to go into great detail here, but as you can see, there are a number of different state agencies that play various roles in healthcare safety and quality. So over on the left, the Department of Public Health, the two main bureaus or main divisions, I should say. That do this work are first the Bureau of Healthcare Safety and Quality. They license healthcare facilities, including the ASCs, and they also have a mandated reporting system for that they're going to be talking about in a bit. The information that they get is public record. On the other side of DPH, actually within the Board of Registration in Medicine, is the Quality and Patient Safety Division. They play a sort of an advisory, consulting, support role in quality and safety improvement. They have a separate mandated reporting system that they will be talking about. And the difference there is that the reports that they receive are confidential. They are not public record. And then over on the right, the Betsy Lehman Center for Patient Safety, we are a state agency. I always like to say it's the only state agency named after a person. We don't play a regulatory role really at all. And we don't have any kind of mandatory reporting, although we do receive from DPH certain reports that the ASCs submit to them, and so but we play more of a convening research tools development research role, and so in fact convening this webinar today is kind of part of that function, the function that we play. Okay, next slide. Okay, so just in terms of, sort of what do things look like today in Massachusetts? One of the things we really want to emphasize is that, preventable patient harm events happen really in all healthcare settings across the continuum of care, and really in every setting. So there's some recent research out of Harvard just in the past year that was based in Massachusetts, found that 7% of ambulatory care patients will experience at least one harm event. This is not exclusive to ASCs. It includes other outpatient settings. The severity of harm, as you can see, is fortunately in many cases the harm is minor, but it can be in 17% of cases severe and even life-threatening in 2% of cases. So takeaway for you is that significant harm, whether it's being identified or not, is happening. It's less than what is happening in acute care hospitals. They have more of a 24% rate of harm, but still very significant. In ambulatory settings, this study found the largest category by far was adverse drug events. 64% of them were adverse drug events. So some infections and also surgical events. Next slide. So if you could go back one slide. There we go. So there's sometimes a tendency to think about when we talk about harm as just those kind of, really catastrophic, permanent cases of, where a patient suffers physical harm. it does, that definition of harm does apply to those cases, but really we want to encourage you to think much more broadly about that, because oftentimes the harm is physical, and it may be short-term or long-term, it might be minor or catastrophic or anything in between. There are also other harms that we really need to kind of be thinking about, which is emotional harms, which we, in research that we have done, has found that those when a patient suffers a harm event, there are usually these pretty significant emotional impacts attached to those events, and they are worse actually in cases where patients feel like the communication in the aftermath of those events, the communication from their providers hasn't been open and helpful. And some of those harms are really quite long lasting. And in those cases, one of the things that we've documented that is most concerning is patients report losing trust in the healthcare system and avoiding all healthcare. So it's a whole range of cases. Go to the next slide. DPH has a specific definition of harm, very consistent with what I was just talking about. It's outlined here. And by the way, we will be sharing these slides after this, so you don't have to be scribbling down notes. You will receive these. But recognizing physical, emotional damage and serious injury in terms of reporting to DPH, more of a focus on serious injury that is, again, not just, like the most severe cases or death, but really any case where a patient in either the short term or the longer term needs some additional care that wouldn't have been required before the event. Next slide. So just want to share with you some recent cases that have been of patient harm that have been reported by ASCs to state agencies, and I will point out, and you will hear in a bit, that the rate of reporting is really very low, but the some of the recent cases are wrong lens implants in cataract surgery, retained foreign objects, so suture needles, perforations, organ perforations during a procedure, medication errors in this case with the syringe not being labeled, resulting in the wrong drug being administered, and then some patient suitability concerns in ASCs, and then falls. So a patient who fell in the ASC's parking lot after a procedure with sedation. So this is just kind of some examples of the kinds of things that are that have been seen and are likely to be seen in ASCs. And I will say there's a common theme among all of these, which they all involved mistakes, obviously, sort of what people think of as the human error by an individual clinician or staff member. But typically, when these errors result in actual harm to a patient, it's a series of mistakes and missed opportunities to prevent the mistakes from harming the patients, and that can be tied back to risks in the ASC's processes or systems that, if they had been addressed, could have prevented the mistakes and the harm. So next slide. So the other thing I just want to leave you with is that we know from research that we've done and research that others have done that most patient harm events are not being identified or reported. And the main reason is, and for the lack of reporting, is that while there may be some willful withholding of information. In most cases, it's simply that the facility didn't detect the harm event, didn't recognize that it was happening in the first place. And that's because, really the way you know about these events is by relying on frontline staff to notice and to use your whatever system you have for reporting internally these events. A lot of times the staff just simply aren't recognizing these events when they're happening. Sometimes they do recognize them, but they fear the consequences of speaking up about them. They worry that either they'll be in trouble or they'll get someone else in trouble, and and also sometimes the sense that the reporting can feel like it's it's extra work, and it feels like it's going into a black hole, and nothing really, no one's going to actually do anything with the information, so why do it? So all kinds of reasons, but just the first and foremost is just not really being on the alert for it, or maybe having a misunderstanding of what a harm event actually is. So okay, so I'm going to turn it over to Terrell Smith, who's going to talk about safety culture and identifying adverse events. Terrell?
Thank you, Barbara. I'm happy to join you all today. Optimal safety cultures are constructed upon structures and processes that prevent harm and ensure systems are designed to minimize risk and enhance patient protections. Safety cultures are integral to quality programs to foster predictable service delivery that avoids both direct harm to patients as well as near misses, which are just as important to mitigate. Strong safety cultures rely on the engagement and commitment of leaders who believe in a systems approach to achieving patient safety, who promote transparency, ensure clear standards are developed, and guide practice consistency to eliminate preventable harm. They help to create environments through systems, structures, standards, tools, and conditions that make it hard for staff to make mistakes. Transparency and communication within and amongst internal teams supports team awareness of safety events while encouraging timely reporting. It's the analysis of those reports which can highlight patterns or systemic issues in care processes that lead to harm events. Next slide, please. Safety cultures rely on robust incident reporting data collection systems. These systems can be manual or on paper or electronic. What's key is the reporting system uses a framework to identify events consistently and foster structured communication amongst the care team to encourage transparency, shared learning, as well as individual and team accountability to improve systems of care. As part of a strong safety culture, the ability to identify a patient safety event or near miss is an opportunity to improve patient safety. When an event or near miss is identified, there's a chance to review potential contributing factors and prevent a recurrence. Next slide, please. One such example is the identification of triggers. Traditional reporting of errors, incidents, and events void of a consistent framework results in underestimates of events. The use of triggers through retrospective record audit alerts the reviewer of potential events and prompts a deeper review to validate if an event has occurred. Next slide, please. The Institute for Healthcare Improvement tool is one of the most widely used trigger tools. There are 53 different triggers to cover a wide swath of potential incidents, from falls to low glucose levels and naloxone administration. When an event is identified, you can then use cause and effect tools like the 5 whys, which puts you in control to determine the focus and scope of processes to improve. IHI has a patient safety tool that is free to download on their website. Next slide, please. This is the example of the 5 Whys tool. The slide depicts a very straightforward tool to target cause and effect to help define which actions would change results. This sample is also on the IHI toolkit. Next slide, please. Thank you. Next, my colleague, Kate Saunders, Director of Quality Improvement, will present on SREs.
Thanks, Terrell. Thank you for the opportunity to share information about serious reportable events to your membership. So I'm going to start by describing the type of SREs that are included in the Bureau of Healthcare Safety and Quality's guidance for ASCs to report. And I just wanted to note, as it was described earlier, the full definition of harm should be applied. That is to say, when identifying SRE events, you should include events that result in changes to the care or the discharge plan, events that cause emotional harm, and patient safety events that require one or more procedures or other unplanned interventions. So Massachusetts adopted the National Quality Forum definitions and their framework for SREs back in 2012. And these are broadly categorized into 7 types of SRE. So the examples are surgical and invasive procedure events. And for an ambulatory surgical center, I would think this would be a very important category. This may include wrong surgery or wrong procedure, wrong site, retention of a foreign object. Those were events that were highlighted earlier by Barbara. Product or device events. This might be a misuse of a device or a malfunction. It may include administering contaminated drugs or biologics or using a contaminated device. Patient protection events would include things like discharging a patient to an unauthorized person. Care management events, such as these may include patient safety events such as medication errors, falls, as was described earlier by Barbara. May also include pressure injuries, loss of specimen, or failure to follow up on a test result, such as a pathology result. Environmental events, this would include events such as burns, injuries related to bed rails or restraints. It could include electric shock or the wrong gas delivered to a patient, for example. And then radiologic events would be a metallic object introduced in the MRI area. Potentially criminal events would include patient abduction, sexual or physical assault of a patient or staff. And I have to say, this actually is a great time of year to be working with the ambulatory surgical centers. We have recently started the process to confirm the calendar year 2025 cases that have been reported to DPH, to the Bureau of Healthcare Safety and Quality. And some ambulatory surgical centers may have recently received communication from myself or my colleague Benedicta asking for confirmation of your plan of correction, of your contact person, including their name, their role, their email, and their phone. And we may be reaching out asking to confirm the SREs that were reported to our Bureau. We've had a few people that were a little bit doubtful when we made these calls and sent these emails. So we want to make sure that, yes, it is really us reaching out to you. And so one of the other questions that has come up during this outreach is, how do ASCs report to the Bureau of Healthcare Safety and Quality? The primary method is through a system called the Healthcare Facility Reporting System, or HCFRS. Some people call it the virtual gateway. Hold on one second. This is a secure web-based system that hospitals and ASCs use to report SREs and complete the quality improvement process with the Bureau of Healthcare Safety and Quality. And my colleague Michelle from the Betsy Lehman Center, if you can drop a link into the chat. This is a link where you can learn more information about how to set up your account, how to update information for your facility. If you've had a changeover in staff, you may want to reach out and make sure that that's correct. Next slide, please. So once a facility, an ambulatory surgical center, has reported an SRE to the Bureau of Healthcare Safety and Quality, kind of what happens. So on this slide, we've given you kind of a very high-level look of what happens, along with the timelines that are required and sort of written in the regulatory guidance. Within 7 days of awareness of the event, facilities complete the case report and submit it to the Bureau of Healthcare Safety and Quality. The facility should begin work on the root cause analysis. And within 30 days, the root cause analysis must be completed, summarized, and any identified corrective actions, all of that should be communicated back through HCFRS. There's another follow-up submission that goes through to the Bureau of Healthcare Safety and Quality. This information must also be provided to the patient or their family, as well as any third-party payer. The Bureau of Healthcare Safety and Quality will review the completed submission, including the 30-day report, and they'll make a determination regarding the final step, whether an on-site survey is required or if the case can be closed via a desk review. After successful completion of this step, the SRE case is closed, and as I mentioned earlier, we do go through a process of confirming events at the end of the calendar year, and we provide basic aggregate counts detailing the SREs and a final calendar year report. I do want to stress here that the SRE timelines for reporting to DPH, notifying the patients and families and communicating to insurers, those are part of our regulation. And these are general, I mean, the 7 days is a deadline and the 30 days is a deadline, but these are the maximum allowable times. You can certainly communicate to a family or patient earlier and more often. The 30-day timeline is for completion of the root cause analysis, and that's placed at 30 days to allow sufficient time to complete the investigation. An ASC may complete and begin to implement changes much more quickly. Next slide, please. One of the reasons we're very pleased to engage with mass ASCs this year is that as was mentioned earlier, we have observed a sharp drop-off in the SRE cases that are reported to the Bureau of Healthcare Safety and Quality by ambulatory surgical centers. On this slide on the left, you see the total number of SREs, and on the right, you see the total SQRs by year for the most recent years. The ASC's rate of reporting of SREs has always been low, but it has been even lower since the pandemic. And in fact, currently we have a 0 for 2025 as well. For SQR submissions, we observed a lower number of submissions with a decline, but then a rebound after the pandemic. Even so, 60% of the ASCs haven't submitted an SQR report in the last 3 years. The orange line is the percent of ASCs that are licensed by DPH that submitted a report in that year. So in 2024, only 9% of those ASCs licensed by DPH submitted an SQR, but that 9% submitted a total of 50 reports. We think there's room for improvement to have all ASCs accurately reporting and engaging in this important QI process. So next slide, please. Thanks. So one of the questions I was asked to respond to in this presentation is, how do we recommend developing a good quality SRE case report, and what advice can we give? Among the best practices I would emphasize is adhering to the reporting timelines, the initial report within 7 days of awareness, and finalizing the report with the root cause analysis and any corrective action within or before the 30-day deadline. Please make every effort to complete the fields in the HCFRS template. That includes patient demographics, relevant clinical and event characteristics, and conditions at the time of the event. The narrative should be concise, but should communicate all relevant information related to the patient's safety event. Please do not include PHI or PII in the narrative. And then I was asked to provide some pitfalls. The biggest one is to ensure that you have finalized and actually submitted the case to DPH. You can go into HCFRS and start a draft and then go back to it, but you have to hit submit at the bottom of the page in order for it to be submitted to us, for us to be able to review it. Beyond that, incomplete values for demographic or clinical or event fields are a challenge for us, and not including enough detail or not the relevant details in the narrative. Those are important items too. Finally, please do respond to DPH when they follow up with questions. The HCFRS account that you use to submit the SRE is associated with a particular email address. And so that would be the person that would be receiving communication from DPH as you work through the process. Any questions? And if not, I'll turn it over to Daniela. Thank you.
Thank you, Kate. So I'm Daniela Brown. I'm the director of the Board of Registration in Medicine, Quality and Patient Safety Division. And one of the things you might be wondering is, well, what's the difference? Why are there two different agencies or two different bureaus asking for this information? As I think Barbara pointed out at the beginning of the webinar, there are some differences in terms of the Bureau of Healthcare Safety and Quality licenses ambulatory surgery centers, whereas the Bureau of Healthcare Safety and Quality provides licenses. The Quality and Patient Safety Division actually is an advisory group. It is something that ASCs are required to participate in. We do use completely separate portals for entering reports and databases. We don't share our reports. So there are times where you do need to submit a report to both agencies, both to the Bureau of Healthcare Safety and Quality and also to the Quality and Patient Safety Division, although it isn't a one-for-one. Not all reports have to be submitted to both agencies. Barbara Fain will actually showcase a nice tool that you can use to determine where your reports need to go. And also, we're always available to answer any questions. So next slide, please. So the Quality and Patient Safety Division oversees what are known as patient care assessment programs in Massachusetts. And as I mentioned, participation in these patient care assessment or this PCA programs is a condition of your licensure, your clinic licensure. So these PCA programs are programs of risk management, quality assurance, peer review, and credentialing. And there are two different types of reports that are required as part of patient care assessment programs. There are a number of resources that we have, including video tutorials that are located both on our website and also if you have an account on our reporting portal, there's a section labeled bookmarks, which will take you right to these videos. One of the reports I'm not going to talk about today, it's what we call the PCA QA report. It's a quality assurance report. There is a new 15-minute video tutorial on the website and in the portal that you can use. I will say, traditionally, our ambulatory surgery centers have been very good about submitting these reports, so I want to thank you for that. But for today, I'm going to talk a little bit about the other type of a report, which are the Safety and Quality Review, or the SQR reports, and these are the patient safety event reports. And unlike the Bureau of Healthcare Safety and Quality, they have 7 types. We actually have 4 types that are reportable to our division. So the first type involves maternal deaths. Second type are deaths that occur in the course of or resulting from ambulatory surgery. The third type are the wrong site, wrong side, wrong procedure events. And the fourth type is a little bit more gray. It's a little less concrete and sometimes difficult for folks to know if it meets the criteria. And as I mentioned earlier, we are always available to answer questions, whether or not something potentially is reportable. And again, Barbara will showcase a tool that might also help you. But essentially, harm events that occur in your clinic, whether they're temporary harm, permanent harm, or death that you didn't expect when the patient presented, are potentially reportable as an SQR report. So moving on to the next slide. I'm going to showcase 4 years worth of data of the reports that were submitted to the Quality and Patient Safety Division, these SQR reports, by ambulatory surgery centers. So 201 reports were submitted to us, and you can see by the larger pie chart, about 40% involved provision of care events and 40% involved surgery procedure events, which makes sense. Then we had some falls, some infections, some delays in diagnosis, and some other events as well. These are the major categories. I'm going to show you in just a minute a little bit more of a deeper dive into these. But I also want to point out the smaller pie chart, which is the harm that was experienced by the patient in the reporting of these 201 events. And you can see that 81% involved temporary harm. So even though there was temporary harm can be quite impactful to patients and clients and their families. And also, if the event happens again, it may not result in temporary harm. The next time, it could be something more permanent or perhaps even more serious, such as death. And I also want to point out something that Terrell mentioned earlier. Actually, I'm sorry, Kate mentioned earlier, that we have about 40% of our ambulatory surgery centers that consistently report these events to us. And I want to thank them. Those reports are quite good, but that means about 60% of the ambulatory surgery centers are not submitting these events, these SQR reports, and there's an opportunity for improvement there. Next slide. So this is a little bit of a deeper dive into some of the themes that we see from what ASCs have been reporting to us. So those 201 reports over the past 4 years. As I mentioned, the provision of care events, most of them were the unanticipated transfer to a higher level of care. You can see that 80 of those 201 reports were those transfers. And if you're looking at those transfers, what we're looking for is that you've actually gone back and assessed or done a review, an analysis of why that may have occurred, that transfer, and specifically looking at your patient selection process. Hopefully you have a criteria that excludes certain patients from having their procedure at an ambulatory surgery center, whether they're, and these are just examples, whether they're oxygen dependent or on dialysis, or maybe they have obstructive sleep apnea, but for whatever reason, you do have some exclusion criteria that you're utilizing when patient selection comes into question. Hopefully you're looking at your pre-procedure optimization of those patients. You're looking at the education that you provided pre-procedure and the assessments that you've performed, looking at your emergency readiness during the event, and also your transfer process. And we have seen some reports come in, patients that are added on last minute. You don't have as much time to go through these, the review of perhaps their optimization or their education. So just making sure that there's awareness that you want to make sure that all is in place before you proceed with the procedure. I have received questions in terms of, well, which patients should we be reporting? We've transferred some patients. Do they all need to be reported? I would ask you to look at the cases. Certainly, if there's a transfer that happens because of an event that happens during the procedure or some event that happens after while they are recovering, certainly those likely would need to be reported. But think about that patient that comes in and you haven't even done anything to them, and they come in with incredibly high blood pressure, and the decision is made, you're going to transfer them out. And you think, well, we didn't even do anything. Why would I need to report that? I would suggest that any patient you transfer out, you need to look at exactly what happened. So maybe in this case, I'm going to give you an example. You looked at the patient selection. That wasn't an issue. The optimization, you optimize the patient accordingly. But in review of the event, you determine that that particular patient misunderstood the education, the directions that were provided. So instead of holding just some of their medications for 5 days, they held all of their medications for 5 days, which contributed to the hypertension and therefore the transfer. So there's an opportunity there to look at all of these elements to determine, could we do things differently? Can we educate these patients in a different manner? So those types of events, I would encourage you to report as an SQR report. But again, looking at each of transfer is an opportunity to look at your own processes. The other events that were reported to us, most of them were surgery procedure events. And you can see here, there were some complications that happened intraoperatively. Some of them occurred postoperatively. We had some wrong site procedures, some falls, some cardiopulmonary events. Most of the intra and postoperative complications were from perforations or hemorrhage or cardiovascular complications that we saw, and so also some injury and infections to eyes. The wrong site surgeries primarily that were reported to us involved the lens or the eye, limb laterality, and joint injections. So there's an opportunity to look at these events and determine which of these events would be reportable as an SQR report. Next slide, please. So what do we do with these reports? Well, just as it is a statutory and regulatory requirement that you participate in patient care assessment programs and that you report these events and submit the required reports, it is also a statutory requirement that we oversee your patient care assessment reports. And we do that, or your programs rather, we do that through the reports. The reports are a window into your patient care assessment programs. And we also use the reports to kind of provide data back to you, the aggregate patient safety event data, to provide awareness of any trends that we're seeing, and also to provide some education and some learning regarding quality assurance and peer review. We do provide resources. If you've been to any of our boot camps or our conferences that we've held out in Worcester, we actually have a spotlight newsletter that comes out. There's actually one coming out very shortly, probably in the next month or so. We issue patient safety alerts if we've noticed trends. But our goal is to support you all in ensuring that you have processes for identifying and reviewing these patient safety events and implementing action plans that include systems and human factors. So moving on to the next slide. How do you develop a good report? I think you had some good advice in terms of using trigger tools to identify events and then using perhaps 5 whys. I like the 5 whys in terms of reviewing an event because it's very simple. But when you're considering how you review the event and considering how you develop any potential action plan, please consider both system factors and potential human factors. And if you've gone to any one of our programs, you've seen this slide before where we reference the VA's root cause analysis system. It's really looking at how you can make your review and action plan stronger. So we see a lot of education in response to these events, and that's great. That's good. The education is always a good place to start. But by itself, you're probably not going to see long-term, change from that. So if you can add several different types of actions, it'll actually strengthen your action plan. The VA considers behavior-focused actions weaker actions, and they're not bad actions, but by themselves, they typically, again, won't affect a lot of change. So these are things that focus on behavior. So providing education, maybe looking at policies, using signs, those are all great things to do and a good place to start. But if you can pair that with a few of the behavior-focused actions or even a moderate action, so a moderate action is when you combine behaviors and systems, so creating checklists and cognitive aids, and if you use standardized communication tools, double checks. If you pair education with simulation, the more you can do, the greater chance you'll have of success of having your action plan actually work. So in addition to looking at systems, you also want to look at human factors. Most people, they don't intend to be involved in an event. But the purpose of looking at human factors is determine if there's anything, again, you can do to improve the process. So if you notice that there's a perforation in we'll say a colonoscopy, and looking at that provider, you look at data that suggests, this is a one-off. This is one event that happened over the last 2 years. It's a very different situation than looking at that same provider and data that maybe you have 4 or 5 perforations that occur in that time period. That suggests that maybe you need to look a little more closely and determine if there's any support that needs to be provided, whether it's tools, education, mentoring, other supports. So looking that you have a good peer review process to determine whether or not you can support someone in terms of improving the systems. And one thing I want to emphasize in the reports that you send to Quality and Patient Safety Division, the SQI reports, we do not want any clinician names. We don't want patient names. We're interested in process, not in specific individuals. But our goal is to help you create strong action plans to mitigate the chance of recurrence of any of these patient safety events. And with that, I'm going to turn it back over to Barbara.
Thanks, Daniela, Kate, and Terrell. Really, really helpful. I'm just going to remind everyone to start putting questions into the chat if you have them, or just think of them, and you can you'll be able to just ask them out loud. If we go to the next slide, so I want to just talk to. There are a lot of resources out there that are freely available to ASCs in supporting you in doing safety planning and improvement. Some of these are actually specific to ASCs. And again, we are going to provide you after this with a complete list and links into these resources. But I want to highlight a couple of things. First. The Betsy Lehman Center is going to, in the next few months, there's going to be an e-learning course that you can that is intended for everyone who plays a role in any healthcare setting, from leadership to frontline staff, even non-clinical frontline staff. We will alert you to that one that's available. And also, as Daniela was mentioning, the QPSD offers just a lot of just supports and around coaching and workshops and events, and we really encourage you to avail yourself of those resources. Next slide. One thing I want to mention is that the Betsy Lehman Center publishes an online but password protected what we call our Adverse Event Learning Exchange. It's essentially it's a repository of all of the SREs that have been reported by hospitals and ASCs in Massachusetts. They're redacted. Any names, although those names are generally not supposed to be included in the reports beforehand, but we do a very careful job of redaction. And the purpose of it, as is suggested by the name, it's really when there's an event in one hospital or one ASC, it's usually pointing to risks that exist elsewhere. And so, we really encourage you to log in, take a look. It's searchable. You can identify the information that is going to be helpful to you. As I mentioned, it's password protected. If you just go into the website, it will prompt you, and we do actually verify that whoever's asking for a password is authorized to have one. Next slide. The other thing I'm going to try to do just very quickly, as Daniela was mentioning, a quick demo of our Patient Safety Navigator, which is an online tool that you do not need a password to access. Yes, I'm just going to share my screen here. Oops, where did it? There we go. Okay. All right. So I hope you're all seeing this. So this is an online tool that, if you're wondering, and the first question in the chat was like, what should I do if I'm not sure if something's reportable? By all means, reach out to the particular agency. But a good starting point is to go to this interactive website. You can see you are all ASCs. You go in through this door, and so these are the reporting required. This helps you literally navigate your reporting requirements. And so I'm going to give you an example. This is going to be the example is a wrong eye that was blocked during a cataract surgery. So that is a surgical or invasive procedure, and then it's going to prompt you with some questions. Did if for SREs or major incidents that would be reported to either DPA, to the Bureau of Healthcare Safety and Quality, or to QPSD. So in this case, this is a surgery or other procedure performed on the wrong site. So the answer will be yes here. But if you're not sure about something, you can click, and this provides DPH's detailed analysis that you can review. It's all in one place for you. You don't have to go hunting for it. So I'm going to click yes here, and then major incident. Yes, this is a type 3, again, a surgical intervention performed on the wrong body part. So there's also more information there if you're not sure, but you click yes, and then here are the reporting instructions. So it's going to give you flow charts. For DPH, this is an SRE, which is reportable to not only to DPH, but you need to disclose to the patient. It gives you the information about that. It even has sample letters that you can use. So a lot of resources there. And whoops. Okay, whoops, this brought me back to the wrong place. So yeah, all right, never try to do this. Here we go. Okay. And so so anyway, it really does kind of walk you through. The other thing it does, and I'm going to have to go back into this. This is just me having not practiced this well enough, but I'm telling you, it's actually a little bit easier to navigate than this. Anyway, it also it gives you reporting instructions, and it gives you flowcharts. I'll just show you one. So this is for DPH, for reporting an SRE, and so tells you what the process is. It also gives you phone numbers, contact information, everything you need to get to where you need to be. So encourage you to access that, to use that. That will be included in the materials that we send you afterwards. So we have some time for questions. So why don't we, you can either raise your hand using the Zoom function, or just wave to us. We'll hopefully see it, or put it in the chat. Okay, I'm seeing a question really. Could you expand on, from Jasmine Smith, can you expand on an SRE report compared to an SQR report? And so who would like to take that? Kate or Daniela, probably.
Do you want me to start, Daniela, and then you can?
Sure, why don't you start?
Okay, so an SRE is very clearly defined. We use the framework established by the National Quality Forum, and there's very clear definitions for SREs. You know, if you can apply the definition for harm, as we have done here during this meeting, I would say report it. If you are unsure if it meets the definition of an SRE, you can do one of two things. You can report it, and working with our SRE team, they may later decide that it was not an SRE, and we can change the designation within the HCFR system so it's listed as a non-SRE. Or you can reach out to them and ask for their guidance and their advice, and I'm sure they would be more than happy to work with you to kind of work through to figure out if it meets the definition of an SRE on our side. And I don't know, Daniela, you wanted to contrast. You have a smaller set of events, so you may want to start with that.
Sure. So yes, essentially the SQR reports, if there's 4 types, but essentially they're all very similar in terms of if it's a harm event that happened at your clinic, your ambulatory surgery center, that you didn't expect it to happen when the patient presented, then it's something that is likely reportable. So harm could mean temporary harm, permanent harm, or death. So a patient is harmed, that is something that potentially is reportable. Our reports are submitted through different portals. So you log on to completely different sites. We don't share the reports. So what you submit to the Bureau of Healthcare Safety and Quality is not something that I know about. And certainly what you submit to me is not something that they know about. So we don't share that information. Their reports are potentially public, where our reports are considered private. The reason for that is because you are submitting information about peer review in the reports that you submit to the QPSD, and that stays confidential. It's afforded statutory confidentiality protections. So that's the purpose of the confidential reporting to our division. With SREs, as Kate pointed out, the first report's due within 7 days, and then the final report's within 30 days. For SQR reports, it's just one report. And the regulations say within 30 days of the end of the calendar quarter that they occur in. But realistically, it's about if we receive them within 4 to 6 months of the date of occurrence, that's what we're interested in. We're looking at, your ability to review systems and your peer review process being reflected in those reports.
And I just
Sometimes, again, you have to report to both. sometimes not. There are some differences. I'm always happy to answer questions. I can just give an example. Some of the SRE reports involve harm to employees, where for SQR reports, it's all patients. Employee-related events are not reported as SQR reports. That's one example.
That's a really good example. Thank you, Daniela. The one thing I wanted to expand on, you mentioned that the SRE reports are public. I would just like to sort of clarify that it's a count. The information that you provide, we provide a count of each type of event, and that is all that we provide. And that is an effort for transparency and for learning for healthcare facilities across Massachusetts. We also provide, as Barbara mentioned, some information to the Betsy Lehman Center to use in their instructions and tools for improving quality of care. Thank you.
Any other questions? I don't see any others in the chat. But
there was one earlier that was asking about whether a center should, if they're unsure, if they should report. And I think we kind of covered it, but I would say yes, if it's one of the defined events for the Bureau of Healthcare Safety and Quality, yes, please do report it. We will have our wonderful SRE team review it and reach out to you. And they may determine that it is not an SRE event, and they can change the categorization within the HCFR system, so it will not appear in your count at the end of the calendar year. But I still think it's important to engage in that process, even if it even if you're unsure if it meets the criteria.
I'm also going to add that we at the Quality and Patient Safety Division, we view those SQR reports in a very positive manner. As I mentioned, it's the window into your patient care assessment programs. It's how we know that you're implementing peer review processes, quality assurance. And so we actually look at it as a very positive thing when you submit those to us. So if we're not hearing from you, then we're not sure essentially about your program. The patient care assessment quality assurance reports, those PCAQA reports, give us a lot of information about some of the activities that you're doing, some of the data you're collecting. The SQR reports tell us how you're operationalizing your patient care assessment program. So they're important for us to receive. So we, again, view them very favorably.
So there's another question. If we still accept faxed SRE reports, if you're not set up on Virtual Gateway, yes, we do. It's just a little bit harder to communicate with you back through the rest of the process. So I would recommend that you get set up on HCFRS or the Virtual Gateway, if at all possible, because there's a communication feature in there, so you can work back and forth with the SRE team on the individual case as you work your way through the process to the final resolution. So I would recommend, if you are able to get yourself set up. It's not that difficult a process. The link that we provided earlier gives a lot of information, and there's an actual person that will help you. Her name and her email address is listed on that website that I provided a link. Her name's Linda Castelletto, and she will help you get set up if you're having challenges.
Great. Well, thank you. We are at time. I want to thank first Greg DeConfilius for inviting this and helping us organize it and rounding all of you up. This is a great attendance, and I hope this information was helpful. I want to thank my colleagues, Tarl, Kate, and Daniela, for their presentations as well. And as I mentioned before, we will follow up actually with an evaluation. We always like to get those back. Like, what was this? Was this information helpful? What else would be helpful? And that list of resources with links, which we really encourage you to use. There's a lot of support out there. Some of it's online, and some of it is actually delivered by human beings who you can actually talk to and are happy to be of help. So thank you all for joining, and have a wonderful rest of your afternoon.
Thank you all for the presentation. Appreciate it.